It's a hot summer July day, and you get called to a local marathon in your community. You arrive on scene and you find a sick runner who's been running for miles. They're altered, they have abnormal vital signs, they look awful. Is this merely just dehydration? Or is it something more sinister, such as hyponatremia, or even hyperthermia, or even high altitude cerebral edema in the right context? How can you tell the difference? Because the treatment for each of those is very different. So you need to be able to recognize it with the limited diagnostic tools we have available to us on the ambulance. Our expert today is the medical director where we currently are on site at the finish line of the Highlonsome, which is a 100-mile endurance race in Colorado. Our expert, Dr. Whitney Barrett, is going to be teaching us all about the ins and outs of approaching the sick runner with a clear algorithmic approach. And our episode today is brought to you by our sponsor, Frontline Optics. Frontline Optics is made for first responders, and as a thank you to Dr. Whitney Barrett, Frontline is providing her with a free pair of sunglasses today. So let's go give her those sunglasses before we jump into the episode. All right, we're here today with our expert, Dr. Whitney Barrett, at the finish line of the Highlonsome, which was the inspiration for today's podcast, The Sick Runner. And in just a second, she's going to teach us all about your approach to the sick runner. But we're finishing up a great race here. It wasn't nearly as hot as it was last year, but things have gone well. And our sponsor for this episode is actually Frontline Optics. And so as a thank you for doing the episode and for, honestly, just running this medical direction for this entire race, they wanted to give you a free pair of sunglasses as a part of thank you for doing the episode. So
thanks. That's awesome. Here we go.
So what do you think?
So they're super nice. They are black with some, actually, when I put them on, the lenses are amazing. Yeah. They super clear and help. My eyes are really tired probably from being up for so long, and just took away all of the glare, which is awesome. My eyes feel better already.
There you go. So you're wearing the Natto Sunset, which have those kind of orangish finish on the lenses. I got the Natto Ghosts on right now. So these are actually made by a paramedic, or they were started by a paramedic in San Diego because he got sick of scratching his designer sunglasses on shift. And so he created his own pair of sunglasses, which are great. And the best part of these are they had a no questions asked replacement policy. So if you scratch or break them, you just email them your order number and they'll send you a new set for free. I think you should pay a $12 shipping or cost or something like that.
That's amazing. That's what everybody needs.
Yeah. And they also donate a portion of each proceeds to the Children's Foundation for Frontline Providers as well. So awesome. Portion of each of these go to a good cause. So if you want your own pair of sunglasses, they're actually giving our listeners a discount, 15% discount if you use the code EMS Cast 15. And so that code is EMS Cast 15. You can go to their website, get a discount. If you want to enter to win a free pair, we're giving away a free pair in September. Just go down to the show notes description, fill out a quick listener survey so we can learn more about you and what you need from us to provide better content. And you can enter to win a free pair in September. And if you don't want to wait, just go use the code EMS Cast 15 on their website.
Awesome. Thank you.
Yeah. Sweet.
It's great.
Yeah.
These are really nice sunglasses.
Here you on 8. Here on 8. Till you're clear, stand by for your base.
Welcome to EMS Cast, where we provide high-level education for you, the providers on the streets. I'm your host, Ross Orpet. I'm a practicing physician, emergency physician in Colorado, and I'm joined by my co-host, Will Berry.
Good evening, Ross. How are you?
Great. How are you doing?
Good. If you're new to the show, I am a practicing critical care flight paramedic in North Carolina. And Ross and I got to know each other working together as paramedics in Colorado. If you're just finding us, we're excited you're here, and tell a friend.
On the show today, we have no stranger, but the infamous Dr. Whitney Barrett, who, if you haven't listened to one of her great episodes on our podcast before, she is an associate professor of emergency medicine at the University of New Mexico. She's soon to be the fellowship director of the EMS fellowship at the University of New Mexico, and she's a medical director for multiple agencies in New Mexico. So Whitney, thanks so much for coming back on the show.
Thanks for having me. It's always a good time.
And so we are entering July. July is running event marathon season. I wanted to talk about the sick runner. Whitney has coaxed me into helping her do some medical aid at a ultra marathon in Buena Vista, Colorado, called the Highlonsome 100. And there are actually some very specific considerations when you're talking about a sick runner at one of these events, or somebody who's running a marathon, or somebody who is just like out for a crazy run for the day. There are some actually very specific things that you may not think about or may not immediately think about when you come across one of these sick runners. So Whitney, that's my intro, but why don't you tell us why you think this topic is important?
Yeah, so thanks, by the way, for coming last year to help with the race. And we'll be looking forward to seeing you again this year for the race. I actually stumbled into medical direction for an ultra event kind of accidentally and felt immediately overwhelmed with how different thinking about some of these patients is in comparison to what we see in the emergency department or what we see in the field. You know, we have a group of people who are usually much healthier than our average population. For those of us who are working just kind of usual emergency medicine or emergency medical services, and they expose themselves to these extreme temperatures or altitudes or durations of time that take a toll on the body in a different way than seems like should be normal. And so thinking about that and how we break down things like, you know, how do we tease out if someone's sodium is low or they're dehydrated or it's the altitude or whatnot when we're in a place that doesn't always have the same tools and resources that we would be used to. Certainly not what we're used to in the hospital, and even not as much as we would be comfortable with in the back of an ambulance. And so thinking through these patients can be just feel a lot different. You know, the 72-year-old grandma who is altered has a very clear pathway that we think about in the field and in the emergency department. But the 37-year-old ultramarathoner who is altered, suddenly it feels like that doesn't fit quite as well to our usual algorithms. Thinking about that can be important, especially ahead of time, as sometimes these patients can be pretty sick.
And these races are only gaining in popularity, right?
Yeah. You know, in advance of talking with you guys, I was like, why can I tell people this is important? And I was actually shocked by how much these events are increasing. As we're seeing over the past 10 years, there's like a 34% increase in males participating in ultra marathons and a 44% increase in females doing the same. And that's specific to ultra marathons. You can imagine, just you think about like general marathons that happen in cities and things like that. I think everyone can kind of anecdotally say, yeah, those seem like they happen all the time, and certainly more than they used to. And so across the board, more and more people are participating, which is great, but also it means that probably the experience of people that are participating is probably lower, which means they might have an increased chance of getting into trouble. And there's just more of them. And so the more people that do stuff, it's our job security, I guess.
Whitney, if we're responding to one of these events or helping cover it, is there any sort of pre-screening that these racers go through before they're allowed to participate?
You know, that is such a great question. And the answer is it depends. In some cases, you know, if you think about like these huge marathons that occur in the big cities, there's certainly not any pre-screening and people sign up at their own risk. When you start talking about some of these more extreme events, I think appropriately so. And when I say extreme events, I mean that is longer distances, usually like more remote terrain. Race directors and people who are participating in the event as volunteers want to have more information because the risk is just higher. And so, like, for example, the race that I help out with, the Highlonsome, is actually a race that people have to qualify for. So they have to have completed a race that is of the same distance or sort of similar difficulty just to be able to, you know, apply to be a part of the race. And so that is helpful in some cases, but the answer is that it can really be variable.
And what's the setup? How are these patients going to show up to an aid station, or if we get activated from the 911 system, how are we going to come across these patients?
Yeah, so it's going to depend a little bit on sort of what the event is, but I'll just speak from my experience, which is for those that probably most people who are not familiar with the Highlonsome 100, it is a 100-mile event that actually traverses 100 miles through the Sawatch mountain range with a change in elevation of, I believe it's like 27,000 feet over the course of the race. So this is like a mountainous, remote trail race. And so there are a lot of those out there, some really famous ones as well. When you are thinking about kind of these races and how people present, they're going to be making their way over a long period of time. This is not like your 6-hour marathon, city marathon. This is like 18, 24, 36 hours that people are out on the trail doing these events. And so depending on where you are and the location of your aid station, there's going to be a lot of variation in terms of what you might see or what the runners might be experiencing. But in general, they're getting themselves to each place kind of on their own. And what you see when they stumbled into the aid station is kind of what you get. So
if we come across one of these sick runners, what are we going to see?
It's interesting. And one of the things that I think that I learned early on is at some point in almost all of these races, every runner in my emergency medicine mind actually looks really sick. I feel like they shouldn't keep going. So that is actually, I think, one of the biggest lessons that I've learned as we've kind of worked through all of this, which is one of the reasons it's great to partner with people who actually have a lot of experience doing these races. But the kind of big categories of things when we think of the folks that are truly sick that we need to intervene on kind of fall in the category of the altered runner, the runner who collapses, and then the runner that has the run-of-the-mill things that we usually think of, right? The STEMI, the stroke, they're unfortunately still possible to have any of those.
Yeah, I can attest to that. When I worked the Highlonsome last year, I was at the 50-mile mark, and something like maybe more than 50% of the runners showed up ataxic, looking awful. And it was amazing. Like 15 minutes, you got broth and calories in them, and suddenly some of them were dancing and then took off and running again. So yeah, you may come across the patient who, if you're responding to an aid station from a 911 service, who showed up, maybe looked terrible. They attempted to give some broth or calories and things didn't get better or progressed and got worse. And that's how you got activated. What are the things we're worrying about in that situation?
We talk a lot about in EMS about scene safety and sort of the context of the patient that you're going to. The same is true when we think about patients that we're responding to in these scenarios. It's just a little bit different than, how is the lighting, how is the whatever else. So thinking about initially sort of what type of race is this? Where is this race traversing across? What type of participants, if you can figure out what this is, if you know more about the race before you're participating in aid stations or responding to it because it's happening in your local area. Is it catering to new people who have never done races before? Or is it catering to people who are super experienced? I think all of those things are going to impact the way that you think about approaching this sick runner. Other things that I like to sort of just keep in the back of my mind as I'm working through, the sick collapsed or the sick altered or just kind of the approach to the sick patient is how far are we from the start? Are we early in the race? Are we late in the race? If we're 10 miles in, everyone should be fine. And so I'm thinking about those things that are much more common, right? It's the STEMI, it's the stroke, it's the sepsis, it's the trauma, it's the whatever. Versus if we're further along in the race, 50 miles in, 60 miles in, you start thinking about some of these other things like electrolyte abnormalities versus dehydration versus the glucose problems and whatnot. I think other things that are important to consider is what is the temperature, what is the time of day? Just because, in Buena Vista, it's 80 degrees and beautiful when you leave your station, right, to respond to a patient who is at Monarch Pass, doesn't mean that person hasn't been at 40 degrees for the last 7 hours. And so thinking about sort of where the runner has been and the certain conditions that they might have been exposed to that aren't always intuitive as we're coming from some comfortable location. So thinking about kind of things like temperature and altitude and how those might be different and how they might have stressed a runner differently can be also a significant consideration.
So a lot of environmental considerations as you're factoring this in. So Given all of those considerations, say you have an altered runner at a station, what's your list of differentials that you're running through?
Yeah, so the altered runner that you come across can be a little bit overwhelming sometimes. The usual things that we can think of obviously are hypoglycemia, but we also think about things like hyponatremia. Depending on the location that you are, you should absolutely think about high altitude cerebral edema or somewhere along that spectrum of altitude, acute altitude illness. Depending on temperatures, considering things like hyperthermia or hypothermia can be important. And then their volume status, if they're severely dehydrated, or the other things that, poor perfusion leads to altered mental status. And so is there some sort of dysrhythmia or something else that might be resulting in this altered mentation?
So when you're kind of have this critical patient, you actually have a really phenomenal algorithm that you use in your protocols, and we can post that to the show notes on the website. But it starts with this. Is it an altered mental status with concerning vital signs, branch point, or was this a collapse? So we've started down the altered mental status, and let's say we have vital signs that are abnormal initially. What is our kind of next step in an approach to that patient with altered mental status?
Yeah, that's a great question. And so I think the first thing that I would emphasize is if someone looks really bad, do your usual things, right? The ABCs are never wrong. And so I want to make sure that we're sort of not including that super sick person that we need to do immediate resuscitation on. But this is the person who is concerning for sure, probably has abnormal vitals, as you sort of described, but we have a little bit of time to start to sort through some of this. So the first piece, the person comes in and they're altered. If you check an initial set of vitals because you're worried about them, absolutely do that. Take those vitals in context, right? We expect tachycardia, we expect, tachypnea, we expect a lot of things like that, but we also expect those things to improve over time. And so as I think about the altered person, there's the altered patient that comes in and looks bad and their vital signs are persistently abnormal, or the altered person who comes in and looks bad and their vital signs normalize as you would expect somebody's to normalize, except they remain altered. And so if we kind of go down the pathway of you get them sitting down, you've provided them, if they're not so altered that they can drink or something like that, or even if they are altered and you're like, I'm not sure I feel great about them ingesting anything yet, you just give them time to rest or heat them up or cool them off or the basic things, and they remain with abnormal vital signs. That's actually helpful as we're starting to think through what could be going on with them. And so obviously somebody who shows up to an aid station is altered and is bradycardic is obviously abnormal, right? Like that's never a thing that we would expect somebody to do. And so, the usual things that we think about that cause abnormal bradycardia are in the ultra runner or in the ultra endurance athlete is going to be something like some sort of like cardiac dysrhythmia, an AV node block, something like that, even though we might not have a EKG that we can obtain, or hypothermia, right? Like that's the other thing that we know can cause bradycardia, assuming that this person hasn't, been taking all of their beta blockers leading into this event or something like that. So we always have to keep sort of the usual things right in mind, but taking this in context, bradycardia has a very short sort of differential for us that could be causing or contributing to that altered mental status. If they're persistently tachycardic and or hypotensive, common things being common, right, is we want to think about severe dehydration. Hopefully there's somebody that can provide a little bit of history for us, or there might be other signs that we can check for. How full is their pack that they've had? Are they completely out of water, or does it look like they haven't been drinking any of their water? Have they been using their electrolytes? And I think it's also important to point out here, some of these races that people have pacers. And so they might actually have had somebody with them for miles or since the last aid station who might be able to provide some additional history. A lot of what we do is treat the common things and see how people respond and then move down an algorithm if they don't respond as we hope them to. So if you suspect dehydration because of tachycardia, because of persistent hypotension, do the easy things, right? Can you orally rehydrate them? Can you get them some electrolytes? Obviously, if they continue to be altered and they continue to have abnormal vitals, thinking about and also taking into consideration where you are, is there a environmental feature that we need to think about? Either hyperthermia, if they're really hot and persistently tachycardic, they might need more aggressive cooling. And then also like more difficult to rule out, but don't forget about like our physical exam, right? Do they have some sort of cardiac arrhythmia? Can you feel their pulse? Is it irregular? Are those things like that present that might put you down sort of some other cardiac dysrhythmia pathway?
So Whitney, I'm thinking about this from the perspective of, let's say I'm called to respond to an aid station as an EMS provider. You guys volunteer at races like this, and presumably, the runner comes into the aid station. Maybe they're presenting this way, they're with you guys or other volunteers for a little bit, and then now I'm being called to potentially like evacuate or transport this patient. So just going off the patient you just described, the severe dehydration patient, first question was kind of simple, but is there a fluid of choice for these folks in systems where we have options?
I think one of the things that is important to also consider as we talk about fluid resuscitation and the altered runner is also the other arm of this altered runner side. And that is to remember that hyponatremia, or somebody who's been drinking too much water, is also a risk. And kind of thinking about fluid resuscitation, how you're resuscitating people and what you're choosing is actually like such a great question and really challenging, I think, in these patients a lot of times. So if you are, relatively certain based on the patient's history and presentation with persistent tachycardia or hypotension or whatnot, you can probably use either LR or NS. Going slowly with your fluids, actually, even though like every part of you will want to just like bolus someone a liter because they're young and they're healthy and it's fine, actually going slowly and thoughtfully is important for people. And we talk about this a lot in our aid stations. If people can take PO, hopefully we've been working on that at the aid station with the person, unless their mental status prohibits us from being able to do that. Providing fluids, but being judicious with them, I think is important. And really making sure as you're moving forward in your patient care that you're doing kind of that constant reassessment. Are we making, important improvements in their vitals in whatever? And if we're going the wrong direction, you got to like kind of sit back and change course potentially. But even with hyponatremia, a liter of fluids is actually probably still fine. It's just not gonna help them a whole lot.
Yeah, I think that was one of my biggest take homes with this was you have a runner who shows up sick appearing, altered, and I think we all think they were just exercising. Most likely this is dehydration. And so our first knee-jerk reaction is like flood them with fluids. When in reality, a lot of these people have been told, don't get dehydrated, don't get dehydrated, don't get... And so people are just chugging fluids, but they forget the electrolytes. And that's when you run into trouble with the hyponatremia, which your standard LR normal saline is not going to fix or help or make better, and may potentially make worse, although a single liter may not. But then also oral rehydration is going to be much more preferred because our gut, especially if we include electrolytes in that oral rehydration, our gut will help sort that out in a more balanced way than just giving them non-normalized saline will. So going back to this algorithm, we have, you talked about runner arrives altered, abnormal vital signs. If it's bradycardic, that's never normal. Think about cardiac arrhythmias or hypothermia. If they arrive, maybe tachycardic, maybe hypotensive, but with a little bit of rest, that resolves, but that altered mental status persists, then what are you thinking about?
So then that's where we're really going to try and hone in on things like electrolyte issues as well as altitude considerations if you need to, right? If your race is at sea level or tops out at 5,000 feet, it's awesome because then you can sort of set that differential piece aside. But with normalized vital signs, thinking about hypoglycemia and hyponatremia are going to be kind of the really big buckets. Obviously, like we talked about, the very first thing you do with all these people who come in and they look terrible is you sit them down, you get them some sort of calories, some sort of, fluids, especially with some electrolytes, and kind of see how they do. So the hypoglycemia piece, assuming that they're not so altered that they can't take in things orally, kind of resolves itself in a lot of different ways. And we might not even know for a lot of patients that really the reason why they looked a little rough was because maybe they were a little bit mildly hypoglycemic.
I mean, I'm sure this is the person we talked about earlier, right? Like came in ataxic, looks terrible, doesn't look like they should continue, take some calories and is dancing and runs off. Nobody checked their sugar, but potentially this is what was going on.
Totally. Yeah, I think, I'm sure somebody has done the study. I haven't looked at it, but I'm sure some percentage of these people are coming through and have either low normal or actually truly low glucose levels, but we fix it. It gets fixed, they move on, and people actually are pretty resilient in the face of that. The person who doesn't improve with just some glucose and a little bit of rehydration, that's where we really start to think, especially with normal vitals, is this somebody who actually has hyponatremia? And history is, we talk about this a lot in emergency medicine. There's all of our diagnostic tools, but a lot of the answer is found in patient histories. And so whether you can get a history from the runner or can get a history from somebody else, how much water have you been drinking? Another thing that's important to consider is, have they been peeing, right? So if you've drank 7 liters of water since the beginning of the race and you're 20 miles in, it's all been free water and you haven't peed at all, you're probably in kind of a bad spot, right? Like that's too much water, and no one is, in general, I should never speak in absolutes. This is emergency medicine after all. In general, people aren't sweating 7 liters of water, regardless of how hot it is or what they're doing. And so thinking about that history, and also it's much more likely in events where there's less experienced runners, because the couch to marathon finisher in the 12-week plan or whatever, they might have maxed out at 16 miles for their training runs. And then race day, they're like, oh, geez, it's warmer than I thought it was going to be. I got to make sure that I hydrate really well. And actually, in ultra events or marathon events or whatever, you should probably be operating most of the time at a slight fluid deficit in order to keep kind of everything in line. So think about hyponatremia, think about the things that can provide some extra information about the risk for hyponatremia. And then exam findings for hyponatremia are actually going to be like people have edema. You can see like lower extremity edema in folks because they are volume overloaded is really what has happened, in a different way than heart failure, in a different way than a lot of the more common things that we think of, but looking for kind of some of that puffiness and whatnot. And then the final one, is high altitude illness. And that should go hand in hand with somebody who has been at high altitudes, usually over, 7,000, 8,000 feet, especially if they've been higher and especially if they've been there for longer periods of time, and should be sort of a progression of symptoms that they might have started experiencing earlier in the race. And so something to keep in mind.
So in our algorithm of altered runner, concerning vitals normalized with some rest, but altered mentation persists, we think about hypoglycemia, hyponatremia, and if appropriate, high altitude cerebral edema. Hypoglycemia, we're going to correct with just some oral intake, some glucose. High altitude cerebral edema, we're going to correct by just bringing that patient off of altitude and down to a more normal level. What about hyponatremia? What are we going to do to treat that in the field?
So it depends a little bit on how sure you are that this is hyponatremia, and also what resources you have, what your scope has been designated as for that event, whether you're a volunteer there or you're just coming to pick somebody up. Hypertonic saline is the end treatment for severe hyponatremia. And when I say severe hyponatremia, that is like the really altered person and or seizing person. And seizures obviously being the most concerning. And so much so that in some places, a patient seizing who is at high risk for hyponatremia, even if you don't have a sodium, is going to get hypertonic saline in small boluses to see if that resolves the seizure. Because importantly, benzodiazepines are probably not actually going to be effective for a hyponatremic seizure. And so that's one of the things, if you have a person who you're like, geez, I hauled them out off of this crazy race, or, not even that crazy of a race, but they were altered at an aid station in the middle of a city during a marathon. And, maybe this is their new seizure disorder or whatever. People who aren't responsive to your benzos also think about hyponatremia, especially in this context. But at the end of the day, the hypertonic saline is the treatment for that. If a person can take oral and, you're suspicious of hyponatremia, basically you give them a whole lot of sodium in a small amount of water, which is disgusting. Some of the agencies that deal with this frequently, it's like, the ramen packets that you can make, probably eat in college or whatever else.
Like
you
the seasoning?
just take, what's that?
Like I think you're going to refer to the little packet of seasoning that's incredibly salty. Yeah.
The seasoning packet. Don't think of just one of those. Think of 2 of those in a glass of water that you're then going to drink.
Yeah.
And it's going to be amazing. You're going to love it. But that is sort of the oral load of sodium when you've got somebody that you're really concerned about it, and you can't get somebody out quickly, or definitive care isn't close by.
I think, we just talked about this in our mushroom episode too. If you have a seizing patient, benzo's never the wrong answer. Benzo's if you have a seizing patient. But we're talking about risk for hyponatremia, given benzos still seizing, think that they may need hypertonic saline if you have it available to you. And definition of hypertonic saline, this is 3% saline. So your normal saline is 0.9% of sodium chloride. Hypertonic saline is 3% of sodium chloride. And usually we give that in 100 cc boluses.
Absolutely.
You mentioned that these patients are retaining fluid. And potentially not urinating. Is there anything particular to ultra endurance events or high intensity exercise that would acutely impair your renal function and make you retain this fluid?
You will now enter into an area of pathophysiology that will very rapidly exceed my knowledge, that has to do with aldosterone and all sorts of things and stressors.
The short answer is maybe.
The answer is absolutely. And there are actually a lot of very good articles that are out there that sort of outline the pathophysiology behind this idea of why, in particular, people who are exerting themselves and drinking a lot of free water, it's like a lot of things in medicine where you get a little off kilter, and then the way the body tries to correct actually probably furthers your problems. And so the short answer is yes, there are a number of stressors that contribute to this. And some of them are actually the things that we do ourselves, right? Like people drink a bunch of water, they've actually had too much water to drink, but then they start feeling bad. And what is the only thing that you've ever heard while you've been outside exercising when you start to feel bad is
drink more water.
You should probably drink some more water. And so I think there's multiple layers as to why.
But my Monday, Wednesday, Friday dialysis patient is not running their 100-mile marathon on a Thursday.
Correct.
Okay.
So moving back along the algorithm, we just talked about altered abnormal vital signs that normalize with rest in our differential. Now, back to the other side of the algorithm, altered patient shows up, abnormal vital signs persist despite rest. If they're persistently tachycardic and hypotensive, we're going to think about severe dehydration, hyperthermia, and hypothermia. Hyperthermia and hypothermia are probably going to be clued in by your environmental factors that you're experiencing right now. If they're hyperthermic, you're going to cool them. If they're hypothermic, you're going to warm them up. If they're dehydrated, you may try a liter of fluids to see if that helps correct some of your vital signs. Or again, oral with electrolytes, definitely preferred. Are there any tricks to like hyperthermia, hypothermia care?
So I think one of the things that's always important to remember, and never the fact that we like, but the thermometers that are most commonly in use, I often refer to as random number generators. If you check a temperature on somebody, especially when we're thinking about hyperthermia, if you check a temp and it's high, it's probably high. But if you check a temp on somebody and it's normal, there's still a chance that it's really high. And so considering what your options are, and, for me as a medical director for a race, I actually feel like it would be poor form for me to not provide some way for volunteers or medical volunteers specifically to check a core temperature, which is almost always going to be a rectal temperature. And so if you don't have access to that, right, because that's not the usual thing that we think of in the ambulance, like, oh, what I really need is a core temperature. Regardless, it is still important to not anchor too much on what that temporal thermometer has provided for you, especially if your patient feels hot to touch, is really flushed, has other signs that might make you think about hyperthermia. The thing that always makes me cringe when I hear people talk about, temperatures that they get is usually we're talking about infection, right? They're like, oh, well, they don't have a fever because their temp was normal. And you're like, well, but they might, they don't have an infection because they didn't have a fever. Well, but they might, right? And the same is true, especially if you're not getting a core temperature in some way. They might not actually have a temperature, but they still could actually be hyperthermic just because we can't obtain a temperature in the appropriate way.
And if we're worried about hyperthermia, what's the best way to treat that?
Cool them, right? And I think in all the paramedic textbooks, or probably EMT textbooks too, it's like, oh, spray them with water and fan them with a towel or something like that. If you're really concerned about a patient being hyperthermic, so much so that they're altered, the fan and the towel are not the thing to do. You want to figure out how you can cool them as quickly as possible, if that is truly the source, or you're most suspicious that that is the source of their altered mental status. So if there's ice available, you're getting ice and that's going in their groin, in their axilla, around their neck. If they're stable enough and you can put them in the river that runs right next to the aid station, cool them in the river right next to the aid station. Time and time again, we've seen the importance of rapid cooling for people who are altered from their hyperthermia. Interestingly, a lot of this data comes from the raves and the electronic dance festivals where people are mixing their drugs with their activity and they can get really hot. And frequently these places are very far from definitive care, and people who get cooled on site before transport tend to do much better, because otherwise people just marinate in their heat until we get them to definitive care. And the ongoing organ failure and everything else just continues. If we can stop that process as quickly as possible, that's good.
Yeah, I think cold water immersion is one of the most effective techniques, which you're not going to be able to do in the back of the ambulance. So I think that's a really good point. If you could find a way to do cold water immersion in a hyperthermic patient on scene, do that. What about hypothermia? How are we warming them?
Yeah, so this can be really hard because you might be in a location where it's just cold, right? Patient, you might not have a lot of heat sources to get people warm. Certainly, if you're responding in your ambulance and you can turn up the heat in the back of someplace and make the environment warm, that is helpful. Other things to keep in mind if you're a volunteer and waiting for definitive care to come, or you're kind of trying to temporize things or see how people recover, obviously making sure that there is some sort of heat source wherever your aid stations are. Heated water in water bottles, especially Nalgene's or other water bottles that actually allow the heat to escape, can be really effective. In the same way that ice in the groin and axilla can be helpful, warm water such that you're not burning somebody with something, right, in a container can be helpful. And then sort of thinking about all those layers of insulation. If people are wet from their sweat or whatever, getting them out of the things that are wet. And then adding heat and then keeping that heat as close to them as possible is probably the most effective way of warming people. The idea of like warmed saline and things like that is a little bit of a myth. It's mostly, if you are giving fluids to somebody who is cold, you don't want to give them ice cold fluids, but if your fluids are warmed, they're probably maybe room temperature at best by the time they get to the person. And so we're probably not going to get a whole lot of gains from, warmed IV fluids. It's really more about how can you warm the person, right, with sort of external warming mechanisms, be it water bottles or external sources of heat, and then keeping that close to them.
And also, like you mentioned, preventing further heat loss. So getting them dry, maybe getting them in a sleeping bag, wrapped in a tarp, and let their body's normal way of heating them up, their metabolism, kind of do its work.
Mm-hmm. And making sure people have calories, making sure that have the energy needed to shiver and do the things that we would want them to do to help them heat themselves. But frequently, this is like a really tough one to overcome in the field, especially if they've gotten really cold, because it's just cold out there.
Yeah, that's a really good point. We need calories to shiver, right? So making sure you're not forgetting that. To complete this algorithm, we have the altered patient abnormal vital signs. If they're bradycardic, that is almost never normal. One of the causes might be hypothermia, which we just talked about how to correct. The other cause may be arrhythmia or like AV nodal blockade. Would you recommend atropine or a trial of atropine in these patients?
That's a great question. I think it depends on how much information you have and how unstable your patient might be. I think if you have the luxury of an EKG, which if you're the person responding to help get this person to definitive care, I think that's great. Anybody who's been on the back end of trying to buy life packs for things or borrow life packs, you know that this is not something that is easily put wherever you want them. And so I think a little bit of that is understanding what resources you have available. Obviously, there can be other electrolyte abnormalities besides just hyponatremia that could be, especially like potassium, that might be contributing in part to cardiac dysrhythmias. I think it's never wrong to, if you've been thoughtful in your approach to what your patient looks like, the information that you have, to sort of follow our normal algorithms for things. If they're bradycardic and hypotensive and altered, you can try some atropine so long as your EKG doesn't suggest that you probably shouldn't. But there's not probably a hard stop on that unless you look at it and you really think that, I think this is their hyperkalemia and not their, just severe sinus bradycardia for some reason.
Okay. So that's the altered runner that shows up. Let's move on to the other side of this algorithm, the runner who collapses. What are we thinking now?
Yeah, so runners collapse a lot. And so these folks can also be sort of dichotomized into two buckets in terms of risk. And so the runner that collapses while running, I'll highlight as kind of always a concerning runner. If things are going okay, nobody should collapse or sync up in the middle of their run. It is much more common for benign causes to be the etiology of a collapse once you stop. And we can talk more about those in a minute. But if you come across a runner and the story is that they were out and while they were running, they collapsed, always think about bad things. And usually those bad things are going to be cardiac dysrhythmias or something else crazy, right? I can throw the whole clown car in there, but it can be their spontaneous subarachnoid or their seizure or their whatever. But in general, the collapse while running is bad and should be taken very seriously. Any collapse should be investigated with seriousness, but we might not end at a point that results in needing emergent transport to some place. There might be other very benign causes for their collapse when stopped. And so I think that's an important first sort of decision point or triage point. A lot of times in the field with like our normal patients, if somebody passes out, that's concerning, right? Like we're like, oh, you shouldn't pass out. We should get you further evaluation. There's a couple reasons. There's two main reasons why runners would more commonly collapse after they have stopped running that might not need transport to the hospital or further cardiac evaluation, like in a definitive setting. And the first one is actually referred to as exercise-associated collapse, which is a very handy name because it is collapse associated with exercise. And so if you think about what happens when you exercise, is a lot of your venous return is happening pretty robustly because your muscles are contracting, they're squeezing your veins, and they're shooting the blood back to your heart, which then is working hard to get blood to your muscles that are demanding oxygen and nutrients and all those sorts of things. When you stop and you're no longer running, your muscles are no longer contracting at sort of the same rate and with the same strength. And so you end up with this sort of like pooling of blood that happens as you're adjusting to your non-moving status. And that pooling causes people to not perfuse their brain like they ought to and collapse, right? It's a like normal syncope. And so that can be a very common cause for people to collapse once they stop. The treatment for that is going to be they're probably already laying down. You're going to elevate their legs, help them sort of reload and provide some extra preload for their heart, and work on oral hydration and those sorts of things to allow their body to kind of acclimate to not being running and return to sort of normal function in that setting.
I would imagine that patient, once they're horizontal, would have in theory, a pretty quick return to like baseline mental status. Is that fair?
Yeah, absolutely. These people should, this is like the person who syncops, is now horizontal. You can talk to them while they're laying down and they're like, oh yeah, geez, that was really bad. They're embarrassed. They wish that hadn't happened. Usual things though, right? Like if they're complaining of chest pain or they're complaining of other like ongoing shortness of breath, those would all be red flags that you're like, like I don't think that I should just chalk this up to some sort of exercise associated collapse. I should probably be a little bit more concerned about this. They might be transiently hypotensive like you would expect, right? But they also should have vital signs that return to normal relatively quickly.
I randomly found out that my previous landlord knew Whitney Barrett for this exact etiology. He actually ran the Highlonsome, and afterwards they have like whiskey at the finish, and he took a couple shots with people as like celebrating, and then felt like super lightheaded, went and laid down in the medical tent, felt a little better. He was like, I gotta really pee, stood up to go pee, and just like with his pants around his ankles, collapsed in the parking lot. And I think Whitney Barrett responded to help him out. So that's just a funny story that reminds me of when you've been exercising, all of your blood vessels have dilated. And if you lay down and try to get up, your blood's going to have a difficult time getting to your brain. But if this happens, like if a runner collapses and this exercise-associated collapse due to what you just talked about is the most common cause, is that what we should just immediately jump to?
No, great question. All of these like more benign causes of collapse should be, like all things, right, our diagnosis of exclusion. So you watch somebody collapse and your first thing should always be to assume the worst. And so we're going to do a kind of rapid assessment of that person, checking your pulses, checking sort of their mental status, all those sorts of things. They might not all, depending on how quickly they recover, they might not all need EKGs. They might not all need us to check their glucose. They might not all need those sort of even that basic of an evaluation. But we should always consider that and constantly be asking ourselves the question, is this actually a bad cause of syncope? Is this actually their cardiac dysrhythmia? Is this actually, something else? And asking the patient questions, asking family or bystanders or anywhere else we can gather sort of additional history to make sure that there's not something that we're missing, right? Did they actually, because runners are clumsy and don't like to admit it, did they actually fall off the trail at some point during the race and hit their head, right? And then they just didn't want to talk about it. And that's actually, now they're at the finish line and they're collapsed in front of us. and not coming to like we would expect them to, we always have to be thinking about those more serious causes for their collapse and checking through some of that stuff, some of our basics before just being like, yeah, man, I pick you up, help you get your pants up, and like send you back to the whiskey tent. But
I'm sure he's gonna love me telling that story. So if somebody collapses, that you have your benign exercise associated collapse, or like a heat syncope where they're not actually hyperthermic, but you remove them from the heat, they return back to normal, give them some hydration. But first you want to think about all the serious causes, and all the serious causes are going to be exactly what we just talked about with the altered runner and abnormal vital signs, with some extra ones too. You're going to want to think about anaphylaxis. If these runs are occurring outside, did they get exposed to some sort of allergen that caused anaphylaxis? And then arrhythmia is going to be a big one as well.
Yeah, absolutely. This is actually a really great time to remember all of your usual paramedic things or first responder things or EMT things, because even though we want this to be related to somebody's exercise or what have you, this is where we want to make sure that we've checked the usual boxes for why people get sick. One of the things that I think is challenging about some of these events is you kind of have to have like the ultra runner problem box, and you have to have the usual person box, and you really actually have to move back and forth kind of seamlessly depending on how your patient is presenting. And that's sometimes a little bit hard. It's like a cognitive shift as we go back and forth to not forget the runner things and to not forget the usual person things.
Well, great. Thanks so much, Whitney. I think this is a phenomenal breakdown of the critically sick runner. If you had to leave all of our listeners with just some take homes, what would be the most important things you say?
So I think one thing to remember, and we talk about this a lot, I think even you guys do a phenomenal job on this podcast with it, the basic things are really important. And those basic things for all of our patients are going to be, in addition to our stabilizing interventions, a good history and a good exam. And that history for the ultra runner is going to be a little bit different than some of our usual things that we think of, but really think about your context and think about the information that's going to help you get to potentially a diagnosis or at least a leading diagnosis for what's going on with your altered runner or your really sick runner. So I think remembering your context and doing a good exam is never the wrong thing to do. So that would be take home number one. I think take home number two is to bring to these races kind of an understanding, like do your homework, right? And it's not like you have to do all the reading about all the events in your county or city or whatnot before you get going, but have an awareness of what's going on in your communities and kind of think through. It's a great opportunity to review some of this kind of less common pathophysiology in case you are called to this. And you know, you probably will be the most well-trained person who shows up, and the opportunity to provide calm and kind of directed care will be so welcomed by everybody who's at the aid station and certainly the patient as well. That is what we can always bring to our shift and always bring to our patients is kind of that extra level of like, yeah, I've thought about what could be going on, and that's what I'm bringing to this scene. And then I think the final piece is I don't think you can talk about any ultra endurance event at this point without just reminding people about these different electrolyte things, especially hyponatremia, and to not assume that the problem is always being dehydrated, but to sort of fall back on that good history, thinking about where you are and all those other things to make sure that you're not missing either the hyponatremia or some other thing that could be contributing to why this person looks sick. Because severe dehydration can certainly make people look bad, but as we talked about today, there's like 100 other things that can also make people look bad, and we've probably not done our patient a good service if we just anchor on that.
Perfect summary. Thanks,
Awesome.
Whitney.